So let me now introduce the speaker. Richard is Associate Professor with the Centre for Health Economics Research and Evaluation at UTS, and he's one of the CRE's Chief Investigator. He's the Senior Evaluator of the PBAC team and Coordinator of the Cancer Research Economics Support Team, CREST, supported by Cancer Australia. Richard commenced his career as an economist with the Reserve Bank of Australia and made the jump through the brilliant but short-lived New South Wales Health Economics Training Program, where in fact, that's where I met Richard for the first time, well over 2 decades ago. He holds a Master of Economics Honours from Sydney University and a Bachelor of Economics Honours from Murdoch University and a PhD from UTS. Richard is a highly experienced and highly regarded health economist, having worked in the public and private sectors as well as academia. He has a keen interest in applied economic evaluations, the economics of specialty health areas, and patient preferences and quality of life and priority setting. Richard's primary interest and focus in specialty health has been the fields of oncology and haematology across a broad range of indications and clinical settings. Today, he's going to bring a few of these primary interests together in his presentations entitled Using Stated Preferences Methods to Explore Broader Concepts of Value in Cancer Care. Please take it away, Richard.
Thank you, Keys, and welcome everybody to this webinar. It's a real pleasure for me to be able to speak to you all today here virtually. Sorry, I'm just making sure that that's working. As Keys said, I'm more than happy for this to be a bit of an interactive session. It would be just as boring for you as it is for me to listen to me speak for 30 to 45 minutes without some interaction. So please stop me, ask questions along the way. As Keith said, the ideas I'm going to speak to you about today do bring together some of the research I've been looking at for a number of years and an interest that I have in how we make decisions, patient preference, cancer, and importantly, this very critical concept of value. Here are my general disclaimers. The most important one is the one at the bottom, which I will try to limit for the purposes of this afternoon. So I thought I'd start the day with highlighting an article that many of you may know, as it helps to ground much of the discussions that we are having now about value-based care and value in cancer care. And for me, one of the takeaways that come from this article is that when we're looking at this idea of value and value-based care, we should be thinking about it as being grounded and always being defined around the patient. What is important to the patient in accessing care and in what they're taking away from that care. And it isn't just about what is, importantly, it's not only about what goes into that care or the costs of producing care, but it's how those costs are achieved relative to the outcomes. So how do we balance outcomes relative to costs, which is a pretty fundamental concept to people like myself and Keys and many others on this call, who are always thinking about that value proposition and how we weigh up what goes into and comes out of the provision of care. And we're also recognizing that outcomes and what we're producing is multidimensional. There are many aspects and many facets to those outcomes of care, and that they vary across care. There isn't a one-size-fits-all approach in what we're thinking about as outcomes and in what we're valuing. So how might we as a population come at this notion of value and determining value? Well, as many of us know, the idea of value is often reflected by what we're prepared to pay. And in a public system like Australia, that comes about in terms of what we're prepared to pay as reflected in something like an incremental cost effectiveness ratio. We look at how much we're prepared to pay relative to its outputs compared to what we're doing at the moment. And committees like the PBAC and MSAC do that all the time. That's not a notion that is only restricted to Australia, but it's something that's happening more and more around the world. Obviously, the UK has been doing it for a long time. New Zealand does it, Canada does it. It happens in Thailand, and even Japan is now doing it to a more or lesser extent. Even in the United States, where we don't have public reimbursement per se, we have ISA, which has adopted its own value assessment framework. where they are looking at these ideas of how we can incorporate value to look at what we're paying for care and ensuring that it represents some notion of value. Interestingly, for ISA, they're not just looking at that assessment based on the comparison of costs and outcomes, but they are establishing some notion of a willingness to pay and looking at prices that are required to achieve that actual willingness to pay threshold as one of their metrics. What's common to many of these approaches is that the outcome that they're interested in is the quality. So that combination of how long people are living and their quality of life, the quality adjusted life year. But that's brought some in the industry to thinking about, well, is the quality broad enough to measure that multidimensionality that I mentioned earlier when we're thinking about value-based care? Is that nexus between the length of life and quality of life enough when we're thinking about value propositions? And indeed, the group, the article I just showed you here, led by Lou Garrison from ISPOR, has produced a taxonomy of potential additions we might like to add to our conceptualization of outcomes when looking at this value proposition and expand on the quality and think about how we can include other outcomes beyond quality of life and potentially length of life in economic evaluations. So some of the things that we're thinking about are values around information, for example. So the value of knowing. So for many diagnostic tests, there is value in understanding what our risks of particular conditions are. Indeed, in the face of a pandemic, the value of knowing what our risk of contagion might be, whether we are going to face increased risks of becoming ill. There's peace of mind from certain treatments and the value of insurance from one treatment versus another. We might want to include disease severity when looking at the value of a new treatment, how that might influence the idea of what we're willing to pay. More and more in cancer, particularly for end of advanced conditions, there is the notion of can we pay for the value of hope, particularly with some conditions like pancreatic cancer or brain tumours. There is an increasing call to factor in whether or not treatments are adding value in terms of adding hope to conditions where there might not otherwise have been treatments available. We can think about potential values also arising from this notion of an option value. That is, by extending life, by making people live longer, we are giving them the potential to benefit from future treatments. Is there a value attached to that? There might also be a sense in which we want to expand our outcomes measurement to allow for better equity of access. And there is a wide movement at the moment, particularly in the health economics space, about how we can adapt economic evaluations to take that into account. Finally, there are some more process related measures around outcomes and how we can change those to take into account the effects of innovations in moving from one treatment to another, and how advances in one area can impact on another area. And indeed, more directly, how the patient's experience of care might lead to value in and of itself. Are patients finding care more or less cumbersome? Are they benefiting from more convenient care? Are they engaging in more shared decision-making and experiencing greater autonomy? And are those aspects all part of the value proposition? So we were interested in this question of whether or not those sorts of broader value propositions were actually being utilised by researchers and individuals when assessing value. And we looked at the literature and found that within publications of economic evaluations that people were actually using some of these concepts to try and get at this notion of value, either through a willingness to pay metric or through a quality of life metric. And that is by trying to put quality of life weights on some of these concepts like information, convenience, or process of receiving care, like shared decision making. And of the papers that we reviewed, what we found was that quite a large proportion, around 28 of those papers, used a technique called stated preference or discrete choice experiments as the means of attaching value to the outcomes that they were investigating. So that we have this broader notion of outcomes, and they were trying to value those broader notions using these discrete choice experiments. And in the next few slides, what I'd like to do is give you a bit of a flavour for what a DCE actually is, and then I'll take you through a couple of examples. So many of you on this, I can't actually see you at the moment because I can only see Keys, but for many of you on this webinar, you will actually have a much more deeper technical understanding of what a DCE that is than I will ever. But DCEs are a survey technique that we use where we can't actually observe in a market how choices are being made. Ordinarily, we can observe in markets how people are making choices, but discrete choice experiments allow us to construct surveys to observe how people might behave in conditions where we can't observe a certain situation. They are therefore based on what we call a hypothetical but realistic scenario that describes a product or service in terms of its underlying characteristics. And I'll show you what I mean in a moment. And we vary those underlying characteristics or attributes between plausible ranges and ask people to make choices about what they would do in varying scenarios. And we use those choices to understand what it is that how people are trading off, and essentially what it is that people are valuing in those different contexts and in different circumstances. The key assumptions underpinning this type of survey-based assessment of how people make choices and in understanding preferences and values is that we can understand choices by comparing the underlying attributes of a product or service that's on offer. This relies on the premise that any good or service can be broken down into those attributes. So for example, we can think about a car as being broken down by whether it's four-wheel drive or two-wheel drive, its color, how fast it goes, its cost, those sorts of things. They're all attributes. And an individual will always choose the combination of attributes on offer that they expect to maximize their well-being. Which combination of these attributes that they're being offered would make someone feel most well off. So here's a bit of an example, a bit topical from today. So imagine that we're offering asking someone whether or not they would participate in a vaccination program. The characteristics or attributes that we might use to explain that vaccination program are things like whether or not there are side effects, who administers that vaccine and where, who should be vaccinated within the community, the proportion of the population that's likely to be vaccinated once it's rolled out, whether or not the vaccine is efficacious in avoiding infection, how much it might cost the individual, and at the moment, whether or not it's going to impact on lockdowns and allow everybody to go out and have some fun. Okay, so these are the sorts of ways that we might conceptualize a program, and hopefully you can start to see that we could think about most programs or products or services in this type of way and breaking it down into its attributes or components. Setting up a DCE and thinking about the problem that we're going to answer is quite critical, and it really does frame the results that you will be able to get out of your research. So if trying to use it to value a particular outcome of interest, then the way that the question is framed is really, really critical. One of the outcomes I alluded to earlier in that broader framework from Garrison was something around the value of hope. And if you could think about that for a moment, then think about, well, could you describe or could you construct a discrete choice experiment that was looking at hope as something that we might try and value? An important thing to consider in thinking about that sort of question is whether or not hope is extrinsic or intrinsic. And what I mean by that is, can you, in the context of an experiment and a survey, just ask someone to imagine that they are feeling more or less hopeful, or that by using a particular product, they will feel more or less hopeful? And I'll let you think about that. And the answer might be no, in most cases, that there are some characteristics or attributes that are very difficult to ask people to imagine. And so we have to think about a different way of potentially getting at those outcomes. And I'll show you an example in a moment. So setting up the problem is very critical. And you can see here the steps we'd go through. I'm not intending to give you a lecture on how to construct a DCE, but these are the steps. The key takeaway from this slide is that how we quantify the question is critical. How we describe the attributes and levels is critical. An important input at this point is to actually have some robust qualitative research, usually with the people who are going to be affected by the program. So if it's about how patients are interacting with the healthcare system, then I would greatly suggest that having patients involved in this qualitative research is critical, and having the patient voice embedded in understanding what the outcome is and in understanding how the outcome is described would really help set this phase of the research up really well. Much of the driving force and the engine behind a discrete choice experiment comes with its mathematical design, and it comes in ensuring that what, as you can imagine, is a very complex combination of attributes and their levels is presented in a way that can be understood by respondents, but importantly allows the analytical framework to investigate the relationships that we're interested in, and to potentially produce or to investigate whether the value propositions that we're interested in can be backed out. And so getting this design right with the help of people who have strong mathematical backgrounds and have experience in experimental design is a really important element of framing, of developing a discrete choice experiment. It helps to set up how the experiment will be rolled out, or is critical in setting up how the experiment will be rolled out, but also in how the analysis will be conducted. Actually implementing a DCE, who you're going to implement it with, will determine the types of information that will be produced. A critical question here in assessing value and how that value is going to be used is who you're going to ask. So if we're interested in coming at values for cancer care, while patients will help us to understand what is critical in terms of the description of the outcomes that we're interested in the descriptions of the service, if the values that come out of this sort of exercise are going to be used in public decision making, then perhaps it's societal preference, society's views on these discrete choice questions that are going to be more important, and we could have a discussion and a debate about that at the end. Getting the surveys completed with enough individuals and having the right number of completions is also critical. That's something that can be worked out during the DCE design phase. Happily, these days, we can do these surveys online so that large surveys can be completed relatively quickly. Of course, if we are doing surveys with patients, it can take much longer to recruit the patient samples required. Nonetheless, it is generally much faster than doing surveys by paper. Analysis of all these data for number crunchers and geeks like me can be a lot of fun, and allows us to interrogate not only what is driving choice within a particular choice context or service in and of itself, but if it's been designed appropriately, it also allows us to look at whether or not value propositions and what is influencing value differs between different groups. And we can potentially assess how something like the value of information or the value of convenience differs between different patient characteristics or different socio-demographic groups. As I said, really depends on making sure that we've designed it correctly to allow us to do that, but it is possible. Now, thanks to developments by people like Nick Bansbach, we can also not only look at value in the context of dollar values, but we can also start to look at value here in terms of quality of life weights, which starts to bring us back to that the notion that the quality can be expanded to bring in some of these broader concepts of what represents value. How we apply this, all of this information that comes out of these sorts of experiments. I've talked about willingness to pay. I've talked about quality of life weights. One of the things I've not talked about is actually looking at uptake. Now, that's really not something I was going to talk about a lot today, but these experiments do tell us about the probability of use, because they're telling us about when people might choose one program, one service over another. And if you're designing a healthcare program, understanding those probabilities of use can be very powerful in helping to set up programs in a way that will be potentially used to their most, in a maximal way. Sorry, that's my home phone, very old school. So let me take you through one brief case study. How embarrassing. Here's an example that we looked at a couple of years ago, where we were looking at the situation of women who were managing breast cancer risk following an initial diagnosis of breast cancer. And we wanted to understand what in that particular situation, what the value was associated with reducing the fear of recurrence in those women once if they were undergoing a contralateral prophylactic mastectomy. So much in the same way as it's difficult to imagine telling someone that they are feeling more or less hopeful, it's also very difficult to ask someone to imagine that they're feeling more or less fearful. The experience of fear is something that's very intrinsic to an individual. So in conceptualizing the discrete choice experiment here, which was looking at the choice between undergoing a contralateral prophylactic mastectomy or continuing to undergo usual monitoring following a breast cancer diagnosis, we couldn't really conceptualize of an attribute that was about how fearful someone felt. But we could have a question after the discrete choice experiment that assessed how the level of fear or cancer concern that people were feeling while they were completing the choice questionnaires. And that's what we did, because we wanted to utilize that rating about cancer concern to then do some subgroup analysis. So you can see here the schema of the overall project. It was grounded in doing qualitative work with women who had undergone contralateral prophylactic mastectomy or not, piloted, and then implemented in looking at whether or not, looking at the choice between CPM or contralateral prophylactic mastectomy or regular management, regular monitoring for breast cancer risk. What we saw, and what we saw is that when we looked at the marginal willingness to pay for our attributes, and we had attributes around the impact on breast sensitivity, the frequency of undergoing scanning, the types of scanning that women underwent, and the impact on breast cancer risk overall, what we saw was that in women who expressed some degree of concern about the cancer coming back, they placed a higher value in avoiding cancer risk and wanted more frequent checkups and wanted to be involved in their decision-making compared to women who didn't express a cancer concern. So when we use that idea of fear of cancer recurrence or cancer concern to try and stratify or to look at how value differed between these groups, we could see some notion of difference. Now, the keen beans among you will say, oh, look, but many of your values there are different. That's due to our sample size, but we are at least starting to see some signals here that are driven by that are according to our difference in these cancer concern levels. And so we can start to see some differences there from that source. Another case study I wanted to run was a recently completed and recently published study looking at genomic approaches to children's cancer care. And here we were looking at the value associated with choosing to participate in genomic medicine in children with cancer. And in particular, we were interested in looking at how the factors that influenced that participation differed between the parents of children who had an advanced pediatric cancer, healthcare practitioners, and the general community. Now, healthcare practitioners in this context was a broad, inclusive statement. So it wasn't only medical practitioners; it included supportive nursing and allied health. Again, this work was informed by extensive pre-qualitative work with parents and healthcare practitioners, and they had identified that hope was something that they were all interested in. You know, they wanted to do anything that they could for their children, and a desire to do what it takes often motivated actions. The attributes that were included in this DCE were things around the survival prognosis, so how sick was the child before they underwent the test, the benefit that they might experience from having a treatment based on a test, whether or not a target could be located as the source of treatment. So could a mutation be found that could be treated, the impact on quality of life of being treated, whether there was a recommendation from a clinician to treat or whether the family supported the treatment. Now, that was a reflexive attribute. So clinicians only ever saw whether or not the family supported the treatment, and families saw whether or not clinicians were recommending treatment. We then had a couple of attributes around cost, which looked separately at who was paying and how much was being paid. And finally, an attribute around the need for a biopsy. What we found across those three groups was that increasing the chance of people participating in genomic medicine increased when we had a higher probability of baseline survival, a higher probability of children living longer if they did find a target, improved quality of life. So improving quality of life following treatment meant people were more likely, a recommendation to participate in a targeted approach, and finding a target. But that was only important for medical practitioners. What we did find, though, was that the importance of those things differed across the groups. So for families and the general population, we found that the quality of life was the most important attribute. So they were really influenced by what was happening around kids' potential quality of life. Whereas for healthcare providers, they were all around, let's make sure that these children are going to live longer. And so we see a slight difference between the two groups in that. Now, healthcare providers were also influenced by quality of life, and you can see that there, but we don't see the same influence of survival benefit for parents and the general community. They were more influenced by quality of life, as I said, and then by things around recommendation and who pays. What we took away from this is that we start to see a little bit of a hierarchy of outcomes in terms of what people were willing to pay, and these are based on the general community sample, where we have quality of life being something that is very highly valued. Shared decision making is also quite highly valued. But we found this interesting idea that there was some level of baseline survival at which people actually were not willing to undergo or recommend that their children be treated, where it was almost the inverse of hope, but it was potentially reflecting some notion of utility, that where children were where the prognosis for a child was so poor and potentially couldn't be improved through quality of life, they didn't want to participate in treatment, reflecting a potential notion of why would we put kids through this if the gain is so small, which we thought was a very interesting finding in this context. So from those two case studies, I wanted to link this back a little bit to some of the discussions that Porter raised through his work. And that is that we can use these sorts of studies to look at how people are making decisions and making choices, but also to start to think about how outcomes might be valued through some sort of hierarchy. And I raise this because through these case studies and through other DCEs that I've seen, either been involved with or have seen, you start to see that there are outcomes which we might call high-level outcomes. Yep, things like efficacy, risk reductions, and quality of life. These are things that are potential drivers, or what I've called an influencer in today's parlance, of value. They are things that we can observe quite readily and have a large impact on people's behaviour and are large contributors to value. But there are other attributes, such as shared decision making and who pays for care, that also influence choice and value, and that perhaps we shouldn't be ignoring when we are thinking about how we pay for care and when we're thinking about what constitutes the value that we attach to care when we're putting forward our value propositions for payments. The other thing is that we can differentiate between groups in terms of how much people, in terms of what people value and how they might value things differently. And that's, again, another important notion to keep in mind when we are looking at what we're paying for care and thinking about the payment systems we might put in place. An interesting proposition, and this is hopefully to foment some discussion, is whether or not we can use these types of studies to investigate how we might pay for care. And indeed, there have been some studies of some DCEs looking at payment systems. I've come across some, or there have been some here locally, but most of the ones I've seen were looking at payment systems in LCMs, looking at how we might structure payment systems for primary care. But could we conceive of constructing a discrete choice experiment around a value-based healthcare system? And if we could, what might that look like? Who would be involved? And how would we go? Whose preferences would we go about eliciting? Julie, I'm nearly finished, and then we'll come to your question. That's all right. So my musings, because this is my last slide, Julie, I promise, is that and I hope you've taken this away, is that this notion of value is broader than what we often measure as a final outcome in clinical studies, and clearly it goes beyond what we put into care in terms of costs. DCEs are a useful tool in helping us to get at some of those different notions of value. They can be a very powerful tool. We do need to be careful in how they are applied and utilized. The way that they're designed is very, very critical. I think there is a lot of potential to utilize them in understanding what matters in the way we assess value, and potentially in helping us to put together programs that better reflect what's value, and potentially to design those payment systems. But there's a lot to nut out in how we might do that. And as my little icon man there says, thank you, everybody. And now we have a couple of questions. Keys, do you want me to go straight to those?
Yes. Would you like me to read them out?
Yes, if you like. Yep.
Or you... Maybe worthwhile reading it out for everybody else who can't see the chat room. So Julie asks, how much variation is there across different countries or cultures?
So, Julie, do you mean within a discrete choice experiment, or do you mean in the practice of applying them?
Hi, Richard. Great to see you. Thank you. I meant, I've got my video and everything on now. I meant if you were to replicate the same research study in a different country, yeah, do it in terms of, you know, the high level things that matter and the other things that matter left, or the individual results, really anything that you can say at all about variation across different countries, and whether or not we can apply results from one country to, or one group of participants to a different group.
Great question. I think we should always be a little bit cautious about directly applying results from one country to another, particularly where we're dealing with some concepts that aren't, where we're dealing with concepts that might not be concrete. So if we're dealing with something like survival, for example, that might be transferable, but when we're starting to deal with things that are less tangible and might be more subject to cultural context, then we need to be very careful and need to ensure that the ideas and concepts are going to translate. So I think local adaptation of a study is always a good idea. I run it in the local context if you can. If you can't do that, then think about, well, how applicable are the methods that have been used there to our local context? And would we expect those results to mirror what's happening here?
Awesome. Thank you so much.
Welcome.
A question from Michelle Richard. Thanks, Richard. Great presentation. We'll echo that. Could you talk a little bit about how information generated from DCEs can be used to inform or supplement current approaches of conducting economic evaluation, or be used in supporting MSAC PVAC decisions?
So I'm very nervous to answer this question because Lloyd and Rosalie are on the call. And I have to put a big caveat that I am answering this as a researcher and not as an evaluator. And so, Michelle, I would say, please look at the guidelines first. Second, I think it can be, so DCEs can be used in economic evaluations. And indeed, there is a very good paper, which I'd be happy to send you the reference to, on how you can incorporate discrete choice experiments into an economic evaluation, either as valuing quality of life or through willingness to pay. When it comes to including them in a reimbursement application, as with anything in a reimbursement application, it is about the clarity of how you're including it, what the methods are, and ensuring that all of that can be well understood, both in terms of what's being done, how it's been applied, and what the implications of it are. And the other thing I'd say is make sure if you're going to include it, that you show results with and without. It's then up to the evaluators and the committee to look at it, what you have done. Right. I think I'm going to stop there before I get myself in trouble.
I think Christabel mentioned that she has struggled to get MSAC to accept this. We'll take that as a comment, Christabel. Lloyd asks, what difference is seen in DCEs between people who enter clinical trials, those with the disease who do not enroll in trials, and persons without the disease?
And then Rosalie's answered it. And Lloyd, we have a ongoing study which will also answer it. So we have a trial in we're part of a study in myeloma at the moment, where the patients enrolling in the study will complete the DCE, and a general population sample have already completed the DCE. And ultimately, when all the trial participants have finished it, we'll be able to compare what the patients in the trial, compare their values with the general population values. So I can't actually answer your question at the moment from a first-hand.
But wouldn't that, I mean, doesn't it depend on what the attributes, the weighting of the attributes, basically? You know, people who enter trials would be hopeful of, they will weight certain attributes. So it's the way you define the attributes across that population. And it's, yeah, it's just always fascinated me about, you know, a discrete choice experiment is going to be, it's going to be put in a context of the individual. Yeah. Because, you know, if someone's got, who weights heavily for hope, will go for clinical trials. They'll go for anything. Others, they will weight other attributes in a different way, because then they decide not to go in the trial. And so there's, right. It's been one of the issues for me about, you know, not the relevance, but the consistency of the argument about DCEs in decision making, basically. It's the weighting of the attributes in the context of people in the trial or that did not go in the trial.
Yeah, and I think, Lloyd, you need to have that comparison. So I guess there's two things there. How have the attributes been chosen? And then how have they been analysed post? In terms of, you know, did the development of the attributes reflect the right choice question? And then in the post situation, how have those decisional contexts that you're alluding to been taken into account in looking at those, at the different population subgroups? So they are things which, so Elena's on that same study with me, things that we will take into, you know, under advisement and look at.
Great, thanks, Richard. Next question from Christabel. My experience of trying to introduce a new treatment in the real world after doing this kind of patient preference work is, as you say, often clinicians are more conservative about accepting risks for better quality than patients. And this can lead to huge barriers to put in a new intervention into practice. How can we weigh and work these two competing interests?
Interesting that you use that word competing, Christabel, because I think they can often be complementary if we sit people down to talk about what they're actually trying to get at. So in the work we did with the genomics, it was, and indeed with some other work that I've done in SMA, it was about making sure, well, it was about getting the two views separately and then sitting down and saying, well, actually, what are people talking about here? Are they really competing, or are they just coming at it from different angles? It wasn't necessarily that the two views were at loggerheads, but as I said, in the presentation, they might weight things slightly differently, but not necessarily in a way that was mutually exclusive. And I think recognizing that they're not mutually exclusive is a really important aspect of what we do, and trying to get people to have that conversation of, okay, so for you, survival is important, so the patient quality of life is important. Let's have a conversation about having those two things coexist. And I don't think that's impossible.
And sorry, I'm going to take Chair's prerogative here. I think that that's a really interesting issue with regards to payment reform, because after all, payment reform tries to address imperfect agency, right? You're trying to align the financial interests of the provider alongside the health and any other utility aspect of the patient and the family. And so that is where there might be, I don't think you're right, it's not always competing, but there might be some circumstances where there is a bit of competing interests. And that's where payment reform could help to try and realign the competition and make them move in the same direction. So your example, the decision-making, the joint decision or shared decision-making, for example, there may be no financial interest in doing that at the moment, but it's something that patients really value. So how could you then create that in a payment system so that there is value for the provider as well as the patient?
I mean, I'm nodding because I'm in vehement agreement.
All right. Good. That's why we work together. Great. So let me move on to the next question from Sarah. Thanks, Richard. Your childhood cancer DCE example was reassuring that quality of life was the most preferred health outcome for parents and the community. All your examples focus
Oh, we just lost Keys.
On health outcomes. Just wondering if...
So we just lost you there a little bit, Keys. But the rest of Sarah's question was about how to include non-health outcomes. People have done PhDs on this topic, Sarah. So it's an interesting question, and so there are avenues to incorporate non-health outcomes like convenience, if you want to call that a non-health outcome, into economic evaluations. You could go down the cost benefit analysis route. I know that's quite controversial. You could do, you could try and assess it on a quality of life scale, or using quality of life weights, either, using a DCE if it's got a survival metric to allow you to do quality weights, or using time trade-offs, for example. And that has been done. The challenges, and Alison alludes to this, is if you're going to do that and then you've got quality of life measured in a trial, do you double count? So it can be done, Sarah, but you've got to be very careful about how you do it. And then you've got to be careful about who's capturing the benefits of that non-health outcome, where the benefit sits.
Yeah, Richard, I probably should have been a bit more specific. I mean, I was thinking specifically about when you generate utility that isn't clinical utility. So, for instance, with the use of genomic tests, when you might achieve value of knowing, so you have a test result, but it has no impact on how that patient is being managed, because it doesn't change the diagnosis, but it might give them peace of mind because they've got a molecular diagnosis. And so, something MSAC has grappled with, we can recognise things like that could then allow you to access, say, the NDIS. So that's, it's not a health impact per se, and it doesn't really, you can't actually put a utility weight on that. It's not I don't think. So
there's been quite a lot of work done in the UK on that particular source of value, and they have looked at how to include it. So there's a body of work on doing that. It's challenging, because what is it that you're actually picking up, and have the studies been framed in a way that will pick up the potential harm that may ensue from that information as well. That's always my worry, is that it's often framed in the positive and not framed in the potential for actual harm associated with people knowing.
Sorry, I hope I haven't frozen on you. Alison asks, great. Alison asks, do you worry that some of what you capture in the DCE is also being captured in the quality of life measurement, therefore introducing double count? Oh, you've answered this question, I think. Was there anything else you wanted to add to that, Richard?
But the only thing thank you, Alison. I think it's a great point to make, which is, if you're measuring something in the clinical trial using a multi-attribute utility instrument, do you really need to supplement it with a discrete choice experiment as well? And you need to think very carefully about that, because you don't want to double count. So, you need to be careful about combining sources of utility values from, disparate places for that very reason. Okay,
Siobhan asks, maybe you want to, does it depend on whether the clinical trial is the only hope? Siobhan, maybe you want to say, the conversation's moved on a little bit, so maybe you want to say what it depends is.
No, I was just going to say, I feel like I'm a buck short and a day late, but that sort of that was in the context of what we were talking about. And it just struck me when you were talking that there's lots of different types of clinical trials, there's you get to the end of your cancer treatment and maybe there's a immunotherapy that might work versus, the trials that are coming out testing whether this is more effective than something else. That was all.
Yeah.
Okay, and Christabel asks, it can be an issue if the provider of the treatment will actually lose money, dare I say. That's we'll take that as a comment as well. Although I was actually going to follow that up, Richard, because I can see one of the great sort of utilities or the uses for DCEs in this is to sort of measure people's risk appetite, because after all,
we're losing you, Keys.
You know, just following up on your mute. So just thinking about shifting risk and whether DCEs have looked at people's appetite for taking on a risk, or at what point as an attribute of doing an activity that has some risk associated with it. Have there been any DCEs that sort of show that where people's appetite for risk sort of cut off?
Short answer, yes.
Right.
So there is again, there's a body of literature that looks at not only risk presentation, but how you can investigate risk in using this sort of survey method, and it is something that you could do to look at how people respond to different risk levels.
Yeah, because I think that would be a really interesting thing to pursue with regards to payment reform, because obviously payment reform will never be implemented if nobody wants to take it up, because they have, you know, the risk appetite is just not there.
Yep.
Any other? We think the chat room has exhausted the questions, but are there any other questions from the floor? No, I think we're all good. Well, in that case, we are almost, well, we are actually out of time anyway. But Richard, can I ask you to put up the last slide of your presentation?
Certainly. Sorry, I forgot about that.
Just with details of the next slide. So thank you so much for coming. It's been a great presentation. So thank you, Richard, for your time and thought-provoking presentation. Thank you for everyone for coming and participating in the discussion. I hope it's been useful. Just to let you know, a few plugs. Our next presentation or next webinar will be held on the 14th of September. You can hold your phone to that QR code right now and register if you like, but obviously if you're part of our network and our mailing list, you will get reminders. Anyway, check out our website. It's improving all the time. It has some content there now, including a new plug for a new section called the Data Corner, which is for all those tech heads out there who love their admin data, but have experienced problems with dealing it. As Denzel always says, who's on this call, all data misbehave. And that is never true or said then for administrative data. So this is a resource that we will keep building on. At the moment, there are only 2 pieces there, but we'll keep building on this as a resource for the entire community who have dealt with admin data and experienced problems with it. And they're just our thoughts on this and our contribution to trying to come up with solutions. So on that note, thank you so much for participating, and hope you have a very productive rest of your day and week wherever you are. Thank you very much.